Welcome to the Scoliosis Dialogues. This is the official podcast of the Scoliosis Research Society. A few housekeeping notes. Abstracts are still open and are open until June 30th for the first Asia Pacific meeting, and registration is open for the 60th annual meeting in Charlotte, North Carolina. We are continuing our series of podcasts for Scoliosis Awareness Month, and we have a pretty special podcast today. This is a bit of a double episode. We're first going to be joined by a former scoliosis patient who's now an orthopedic surgery resident. That's Dr. Lara Cohen. And then after that, we'll be joined by our current president, Dr. Laurel Blakemore. Dr. Cohen is a resident at the Harvard Combined Orthopedic Residency Program, or HCOR for those in the know, and she will very soon be applying for fellowship in pediatric orthopedics with the goal of becoming a pediatric spine deformity surgeon. I have it on good authority that she's on night float right now and that the intern is holding the pager so she can do this. And so thank you so much, Dr. Cohen, for coming to spend time with us.
Thank you. And thank you to the intern.
Absolutely. Thank you to the unnamed but very appreciated intern.
Yes.
So, Lara, tell us a little bit about yourself, maybe just a little bit of professional history before we get into you as a scoliosis patient.
Sure. So I was born and raised in New York, grew up there, and subsequently found myself early on in the very niche field of pediatric orthopedics and pediatric spine surgery. In part by virtue of my own scoliosis journey, I did some research at the Hospital for Special Surgery and then came to Boston for college and went to Boston University, where I got a degree in human physiology and worked within the pediatric orthopedic department at Boston Children's throughout my time there. Stayed on at that position for some time, growing as a research coordinator. Also earned my master's of public health at Boston University before heading down to Miami for the medical school at the University of Miami. Now I'm back up here for residency, almost entering my fourth year and gearing up to apply for pediatric orthopedic fellowship.
So would you mind sharing kind of when and how you were first diagnosed with scoliosis?
Yeah. So I was picked up during I think probably in fourth or fifth grade. So I was about 9, I think, at the time I was officially diagnosed. And I just remember it being flagged at school, going to the pediatrician, who then referred me to a pediatric orthopedic surgeon, and kind of got heavily involved in the treatment process at that point.
So in the first visit, most of us, whether it's true or not, think that we're really good at talking to patients and families. But it turns out that a lot of us probably aren't. So, what is the insight that I lack that you can share with me to make me better at talking to a young person during that very first visit?
Yeah, I think, I remember now kind of looking back as someone with a lot more insight into this. It was probably the sort of patient that they could have told me from the jump that it would involve some sort of treatment like bracing. But I remember our first appointment was very much just a general overview with very quick follow-up scheduled, probably knowing I'd have to be braced, but not prescribing that at the first appointment, which I think is helpful. I think the biggest thing is just making sure that you kind of lay out everything appropriately for both the patient and the parent level. And I think the things my parents were most concerned about were things that weren't even on my mind at that age, and vice versa. And especially from like social concerns and kind of adjusting to wearing a back brace, I think there's really different perspectives of the patient and the family. And so covering all those early on is important in building trust.
It's a really good point you make. That the very first time you met, you didn't go into a brace. You had maybe a very short follow-up interval, maybe a
Yeah.
little bit of trust, a little bit of extra information for your parents, and then started bracing after that.
Yeah.
And I think we miss that opportunity sometimes to build trust by saying, "Oh, you've got to go into this brace today," rather than letting it simmer a little bit and saying, "Hey, I'm going to see you in a month, and we're going to talk about this again."
Yeah. And I think I remember it so vividly because we very much shopped for opinions early on. I remember, and now I look back at it like, and there's so much more you understand when you're in it. But I remember we went to one surgeon who's well known, recommended an MRI, which, you know, age and different characteristics about my curvature, I think was more than appropriate. And, you know, that completely freaked my parents out. And I think maybe just using the first visit to kind of lay the lay the groundwork before jumping into treatment decisions is helpful, especially for certain families.
Yeah. So obviously, over time, you developed a very trusting relationship with someone who took care of you, and it impacted you in such a way that we're on this Zoom together today. And
Yeah.
so, who took care of you? What is this person doing right? And how did that relationship evolve over time? Like,
Yeah.
how can I get to the point where I have patients who are one day on the SRS podcast with me?
Fair enough. No pressure. My doctor was Dr. Boachia J, so I was pretty lucky. He was at hospital for special surgery, really, really special person to me, and obviously incredible pediatric spine surgeon. And so he really did a great job of developing, you know, a personal relationship with me and my family and kind of earning our trust early on in the process, which facilitated a long relationship with him as a patient and, you know, with my sister who also has scoliosis and that sort of thing. Um, you know, the way it evolved was I think I had found myself frequently in the doctor's office as, you know, someone that was diagnosed with scoliosis young. You're coming every few months for appointments, and at that age, like you're growing out of your brace every year or so. And so I was there all the time. And he just had such a way of teaching at an appropriate level that I was like, this seems like something I could enjoy doing. And really fostered that interest in science for me early on. I actually had a science research program through high school. And looking back, you know, people do all sorts of like little bedroom science projects, but I thought I'll just ask Dr. B if I can work at HSS with him. And he said, sure. So that was kind of my early foray into science research.
How old were you at the time?
I started formally going in and interning when I was 15 or 16.
Like that's a pretty early start and a lot of initiative. Like I'm a 15-year-old and I'm just going to roll into HSS and say, "Hi, I'd like to do research here today."
Yeah. It was like a part-time HSS intern, part-time. I was like either serving somewhere, lifeguarding, like junior lifeguard.
That's incredible. No,
Yeah.
that's absolutely amazing. And so as someone who wants to do this with their life
Yeah.
and has been in the clinics, um, how do you use your own experience or how do you plan to use your experience to communicate with young patients and families?
Yeah, I think the biggest takeaway is just knowing how to time out the clinic visit. Something really interesting to me about pediatric spine surgery and that kind of differentiates it from the other orthopedic subspecialties is I think there's a lot of thought and planning that has to go into clinic, and I actually kind of enjoy the relationships that you develop in clinic there. Um, I think sometimes clinic can feel like a task, but in pediatric spine, you're really, you know, laying the groundwork for developing long-standing relationships with these patients and these families. Um, and so I think I've got, you know, obviously insight as a patient as to how I would prefer the groundwork to be laid for myself and my family. Um, Kind of taking it slow, like we talked about at certain points, and building trust early on.
So you talked a little bit about enjoying clinic and enjoying the kind of the long-term relationships. And I
Yeah,
agree with you. As a pediatric spine surgeon, I feel like we're cheating the system
yeah,
because we get the long-term gratification of knowing our patients and knowing their families, and also the immediate gratification that comes with being a surgeon.
mhm,
Um, and so with that in mind, outside of the clinic, you've seen a lot of pediatric and adult spine deformity surgery, some of which likely has led to complications or even devastating outcomes. So
yeah.
why in the world have you chosen to do this?
Yeah. I think everyone kind of figures out during orthopedic residency for themselves what sort of risk benefit they're willing to take on in future practice. To me, the reward of developing relationships with these patients and these families and the interest that I have in scoliosis, and especially the kind of unsolved mystery component of a lot of early onset and congenital scoliosis, um, is worth it to me for the potential complications. I think you need to be really invested in the field and have good mentors, to be well educated on future complications and missteps and be mindful. But it's kind of a stress and a risk that I'm willing to take on because of how interesting I find it and how fulfilling I think the field is.
I think you're spot on. I think you've made a very wise choice. And so, last question for you, and this is a little bit of inside baseball, and hopefully will help us within our own fellowship program in Boston. But as somebody who's starting right now the fellowship application process, ready to jump on planes all over the country and meet everybody, and we've got to convince you to come to our hospitals. So, what are you looking for? What is a young person today really wanting out of their fellowship experience?
Yeah, I think a lot of that depends on if you're planning to subspecialize within pediatric orthopedics or not. And I know, this is a conversation we've had plenty of times. I think anyone planning on becoming a pediatric orthopedic surgeon needs to have good bread and butter pediatric trauma training. And so I think step one is making sure you're going to a program where you can comfortably get that and have the autonomy and the reps to feel okay doing the basics of PD trauma call. I think the next question is, am I going to be a general pediatric orthopedic surgeon, or am I trying to do something really niche like pediatric spine surgery? And if I am going down that niche pathway, am I going to get there during just this fellowship, or am I planning on doing supplemental training afterwards? And if the plan or the hope is to just get there through 1 year of training, I think you need to find a place that really has the number of cases, diversity of cases. I don't think if you just go somewhere that's, doing nice fusions and selective thoracic fusions every day, you're going to be the right person to evaluate even what might look like a standard AIS patient, and treat the more complex cases. And then find a place that's doing the right balance of the old and the new. At IKEOS last year, a lot of people talk about, making sure that residents and trainees are comfortable with like old school placing pedicle screws, not using navigation. I think that's super important and probably something that's unfortunately going to be lost on a lot of my generation, depending on where they train. So kind of balancing that with, okay, I know how to use navigation and I know how to use the robot and I know about tethering and the new stuff. Even if I don't agree with it, I don't think you can really give an opinion on something without having experienced it.
That's spot on. And I think it's interesting because I was looking for the same things 13 or 14 years ago that you're looking for today. It's just the new is a little bit different now than it was, 13, 14 years ago. But I think the things that we struggle with as we make these decisions are very similar across generations. And so now we're going to transition just a little bit. I'm going to step back and join my own version of the peanut gallery. And Dr. Cohen is going to take over as the interviewer, really interviewing none other than our current president, Dr. Laurel Blakemore, with a focused discussion about going from trainee to young surgeon to established surgeon, all the way up to SRS president. And so the floor is yours.
Awesome. Dr. Lake, we're excited to chat with you.
Me too.
question. I just was hoping you could kind of go over your path to pediatric spine surgery. I know this is something I even struggle thinking about today. What's the proper path and how do people find themselves in this sort of subspecialty?
My path was probably like, well, my path in general, I would say in my career has been a little zigzaggy. I wasn't in college, I was thinking about medicine, but I was also thinking about, I was a creative writing major. Like I sort of hedged my bets and did a lot of science, but also a lot of not science. Um, but I knew I thought about other careers, but I knew I really wanted to do something where I felt like I was contributing. I just didn't think I'd be personally satisfied doing something, some of the other things I sort of enjoyed, but as a career, I wanted to have a career where I felt like I had that satisfaction. So that turned out to be really important. And then choosing orthopedics, again, like I had a lot of different things I liked. That turned out all to be surgical specialties, but my brother's an ophthalmologist. He was trying to make me go into ophthalmology. It was cool. It was kind of like astronomy, but not for me, but I tried to love lots of different things, but there's just like you, I'm sure, there's so many cool things about orthopedics that I really made sense to me. And then pediatric orthopedics, I think, was a pretty natural fit because I I just really enjoyed that population. I loved the ones that nobody else wanted to see in the clinic when I was a
Yeah.
resident. I was delighted to go see them. And even though I was not a parent at that point, I felt like it was easy for me to understand the parent's point of view. And I really enjoyed that.
Yeah.
Spine surgery was almost, and maybe this may be true for a lot of us in spine surgery. You kind of deviate sometimes towards the most difficult problem you see and think, God, I'd like to solve that. I mean, total joints are pretty good, right? And in pediatric orthopedics, we do a good job with supracollar humerus fractures, and we all love trauma, but do we do a good job with the 4-year-old with a 75-degree congenital curve? I mean, that's a really hard problem, and so I think many of us go into early onset scoliosis in particular, but pediatric spine surgery because I'm not sure the solutions we have are really the best ones. The best ones we've got, and we were working really hard to get better ones, but I'm not completely convinced that in 20 years, the best solution for a big thoracic curve is going to be, pulling all the muscle off the bone and sticking all the bones together with screws.
Yeah.
We'll see. So I think it's a really great field for people that like to continually feel like, God, I can find a better way. Let's look for better ways. So think that's how I ended up where I am.
Awesome. Were there any key relationships you had early on with mentors or any specific mentors that really pushed you into this field?
Yes, I was very fortunate, and I'm still very grateful to work with some really great pediatric orthopedic surgeons early in my career. So I trained at Michigan. Bob Hensinger was the chief, and he was the triple threat. He'd been president of the academy, president of SRS, president of POSNA. He was an unbelievably good thinker. And Fran Farley was the chief, and they just had really great ideas. And you'd find Bob Hensinger smoking at that point in the office on a Saturday morning if you go in, and he'd be, thinking about stuff like congenital scoliosis or hip dysplasia or and he would sit and talk to anybody who was brave enough to go into his office for an hour. And so I learned a tremendous amount from him. Obviously, also from my fellowship directors, I did my fellowship at Case Western. Um, but I think that as a resident, that's where I really sort of got turned on to things by my mentors. I've
Yeah.
also I've also I think when you're a learner, it's really important to pick. You don't have to just have the mentors from your program. You can wander up to people and pick them. I mean, I learned a lot from Tony Herring, and I never trained a Scottish Rite. But he was nice enough to talk to me when I'd call for, if I had questions or he actually became a good friend. So I mean, I think you can also just pick people who you think their interests are good or you like the way they talk or teach at a lecture. And it is I feel that it's a very generous community with their time and they're anxious to pass on what they know and help other, younger surgeons get better. So I think that you almost can't go wrong with most, at least with most of the people that Grant and I would know that are really passionate about pediatric spine deformities, spine conditions. Um, so you can kind of pick your own path a little bit, but it's great to start with a program that has some strong people.
Definitely. Going off of that, is there any, key advice you've given when now mentoring others, and especially women pursuing spine surgery or pediatric spine surgery?
I was thinking about you because I mean you're obviously so great. I was like, oh God, I hope you apply to our fellowship. It's wonderful to hear how you've developed and how you I think feel like got stronger in terms of your interest. It didn't back you off, which makes me super happy. Like we at least did a great job in that sense. And I'm actually currently have a research assistant for the summer, like a summer internship patient who I did spine surgery on her for scoliosis about a year ago, and she wants to look at sort of concordance between your first visit impression for the caregiver, for the parents. We should probably do the patients too, but I treat a lot of early onset kids. So sort of what did they get at? Like, did they understand the diagnosis? Did they understand the treatment options? And then ask the caregiver if they felt like those things were understood or not.
Mhm.
I think the fact that she wants to study that tells me that she probably experienced that maybe she and her parents were a little bewildered the first
Yeah.
time. And it's such a hard conversation if you meet somebody. I'm sure you have seen this, and Grant knows this. You meet somebody and they've got a 70-degree curve. You'd love to have a conversation about conservative treatment or waiting, but sometimes I feel like we have to have this talk today, and I know it's awkward and you don't know me yet, but we have to talk about this. I mean, I know some people just have them come back in a few weeks, and that's probably not a terrible idea either. But you have to broach the subject that this isn't a curve. They're going to ask if that curve can be treated with therapy or something like that, and you're going to have to tell them that at this point, that's the options are surgical, and that's obviously a very difficult first conversation.
Yeah.
Um, so anyway, so back to the mentor question. I think that um, I've really gotten much better at being open about the fact that it's great to have people, young women going into spine surgery. I think 30 years ago, I didn't know quite how to lead that, but now it's just makes perfect sense to me. And we've kind of hit a critical mass, I feel like, of in some underrepresented groups in or in orthopedic surgery that even though it's still a minority, there's enough people that it doesn't feel like you don't feel like a token.
Yeah.
You there might not be the majority women, but you're not like, it's not like one woman out of 30 in your program, or, there's enough traction now. It just doesn't seem weird for me it seems natural to go ahead and mentor women if that's what they want to do. So I'm much more, I would say, at ease with doing that. And there's lots and lots of great young women up and coming or pediatric orthopedic surgeons to choose from. Like if I can think of people for talks, I can think of lots of people, and that includes women. And I don't feel
Right.
like I'm purposely trying to pick out a woman to put in a faculty because there's lots of good choices.
Yeah, I think that's one of the big things, and what, has stood out to me about like different orthopedic residencies when I was applying and now looking at fellowships, like not wanting to be in a position of being the token something, but feeling comfortable there because it's just kind of a natural progression, and that's what the faculty looks like.
Yeah, it's hard. It's hard for programs that have not been as diverse in gender, in ethnic background. It's hard for those programs it's because it's hard to be the first.
Yeah.
Even if those programs are trying to be very open and welcoming and turn a page, it's if they don't have that history and that critical mass of members already that look more like the applicants, it can be hard to get that going. I know at University of Florida, when I went to Florida, there were no women on faculty, and
Yeah.
no women went. The last one woman resident and graduated, so no women residents. And so, I went to every interview for
Yeah.
every group of residents until they got a little traction. Now they've very successfully recruited women there and have lots of women on faculty. So you just kind of got to get the ball rolling sometimes.
Yeah, definitely. Um, what early career opportunities do you think, aside from obviously residency and fellowship training helped you prepare for taking on so much leadership in your career and obviously, becoming the SRS president?
I think good examples. I mean, I think I was lucky enough to be at a program that had a strong history in terms of academic leadership. So it seemed natural to me to volunteer in the society role. I didn't, I think one mistake I made, or I wasn't very good at in my early career. I didn't really understand the value of volunteering and being part of local leadership. I was really interested in society leadership and education. And I came at it from, I wasn't like a super strong NIH sponsored researcher, but I did research. I loved research, but I really was an educator. And I had done a lot of work in orthopedic adult education. So um, I feel like that was a good direction for me. But I sort of wish I'd learned more about hospital leadership because then I kind of had to catch up in the second half of my career. So I think try a little of everything. I think, be on a few hospital committees, see if you like that kind of leadership role where you work with multiple different specialties. For sure, be involved with your society, especially like, so for us, POSNA or SRS, and just see, you may find there's some specialties, some societies that you don't necessarily want to have a leading role in, but you still can contribute and give back. And you get a lot from giving back to, I mean, you get a lot more, I feel like, out of society than I give to the society a lot, but I've gotten so much more out of it in terms of education and camaraderie and leadership experience. And so for me, that's been extremely valuable. I'm very grateful that like this SRS took chances on me when I was a younger person. Got to be program chair and got to do the things I could do to show that I was willing to work hard enough to make those things successful. So I think try a little of everything to start and then see what leadership appeals to you. Like you don't have to go do a master's in business to be interested in hospital leadership. It probably helps, but lots of people have, and I didn't. And I'm
Yeah.
in a CEO role right now. So
Okay. One last question to wrap it up, and something I think about a lot is a young trainee and kind of embarking into the crazy world of pediatric spine surgery in any field, but especially in this field, like we talked about, there's constantly evolving treatments, new treatments, hot ideas that maybe come and go rather quickly. Where do you feel like you've fallen on the technology adoption curve throughout your career, and how has that changed from a trainee to a young attending and now in your career?
Oh, I'm much braver about questioning the status quo now than I was. I mean, I like you get like it's like the first 10 years of my career, if I was told something or read something in a paper, like that was the way it was supposed to be done. But I think question, like ask, is this really the best way to, I mean, it's the best we got, but is it really the best way to treat a very beautiful, complex thing like the way the spine works by sticking all the bones together? I mean, it accomplishes our goals and we have remarkably good long-term outcomes. But are there better things? I don't know about you, Grant, but I mean, I've been a little bit on the, I haven't been the cutting edge person for most things, but I was a pretty early adopter. So I wasn't necessarily a pioneering adopter, but rather an early adopter. So I've done a few robot cases. I started tethering in 2014 pretty selectively, but so I've tried to be part of people learning about new technologies, but I also I think when you're adopting new technology, it's extremely important to do it in a very um, controlled way, in a very scientific way, like the way that you can study, not to just go out there and do a bunch of
Right.
something, but really to study your results, to be part of a study group, part of a group that's looking at the outcomes for something as carefully as possible. And I think for the most part, Tether's being introduced in a responsible way with full acknowledgement of the limitations we encounter as it goes. I think it's such as if that is an example, it's such a tempting um, strategy to use growth to get the spine straighter. So maybe the tethering's not there, but something like that will be a
Right.
really good answer. If you can identify a curve early enough and use the growth to get it to correct the problem rather than let the problem get really big and then make it stiff, then I think that'll be a really great. So we're in a stepwise process, I would say.
Yeah. And I think being able to really critically evaluate those things and decide if they're right for you, a lot of that is just part of being a member in these societies and having trustworthy mentors that you can kind of talk through things with.
Yeah, and some of your mentors are not going to want to tell you to adopt new technology, and some of them are going to be, one of the early adopters, maybe like right on the forefront, and you make your own decisions. But there's a lot of opportunities to get training in those things, and that's part of how you decide. You can go do, you can watch someone do a new technology. They'll be a good surgeon will always be honest with someone like that comes to visit and about their mistakes in an early adaptation of a new technology. And so you kind of hear about it and you find out what their challenges are, and then you can decide, are you going to join them? Or are you going to sit back and wait and see if it works and then adopt it? That's okay too. That's totally okay. You just have to see where your personality fits in that spectrum of adoption.
Yeah.
Such a good point about the adoption spectrum and then who you trust, right? So first is, are you the tip of the spear? Are you the second wave, or are you the curmudgeon? And probably early in your career, it's always good to be second wave.
Yeah.
And then as you are more and more senior, you have opportunities to be the curmudgeon or the tip of the spear.
Yeah.
And then the second part of that is who you trust. And I think you made a really good point about people coming first with their complications and being honest about that. Because I think that's whether it's robotics, navigation, tethering, or whatever the next new thing is. Coming with your complications first and working from there is a really honest way to approach any advancement in medicine.
Yeah.
And so we are going to start wrapping this up, just as Dr. Cohen said. I want to thank you both for your time. This has really been incredible, and I think it shows a nice transition between people as patients and then as physicians and then as mentees and mentors. I hope that this really gets out to a lot of SRS surgeons as well as potentially families who are going through something similar to what you did, Dr. Cohen. And I would make one plug for the SRS in terms of mentorship. The SRS is very special. Myself and Dr. Blakemore are both pediatric orthopedic surgeons. Dr. Cohen, you're about to apply for pediatric orthopedic fellowship. But within the SRS, you can have mentors that are pediatric neurosurgeons, adult neurosurgeons, adult spine surgeons. I don't know that there is another group that is available to us that has such a diversity of training and diversity of thought process. And it's really what makes the SRS so strong.
That's a great point. Yeah, it is. It is really I do love the SRS. That's a very unique combination. I think we've successfully brought in all the people, we need. I mean, there's always more work to be done, but we bring in all the people that are looking at the same problem we are, I think, very successfully. Pediatric neurosurgeons, adult neurosurgeons, spinal surgeons, non-operative specialists, people that do orthotics work and physiotherapy. So we're really trying. I think it's a very open-minded group trying to understand what the best ways to get good outcomes are, and it may not be what we do.
Absolutely. And I think we can leave it as that. Final thoughts from the president. Thank you both so much, and I hope you have a good evening.
Thank you. We're really excited to see where your career goes, Dr. Cohen.
Thanks.